Welcome to the Real GI Doc Show. I am your host, Dr. Fred Gandolfo, and I'm a board-certified gastroenterologist with a medical practice in New York. On today's episode, I'm going to cover some of the diet and lifestyle changes that you should make if you are one of the more than 30% of Americans currently diagnosed with fatty liver disease. First, I will define and discuss exactly what fatty liver disease is, and I'll also discuss how it happens and why it happens. But the real focus of today's show will be about the safe, natural, and effective treatment for fatty liver disease that you can do at home with little or no cost. Sure, there are some expensive medications and even surgery that you can do to treat fatty liver disease, and many of these interventions are quite effective, but that's a topic for another episode. This episode is going to tie into next week's episode, where I will discuss the psychology behind making diet and lifestyle changes when you are faced with medical problems. So, if you have fatty liver disease or want to prevent it, be sure to listen to the end of this episode. So let's get right into it with the patient case. And by the way, there's no disclaimer needed today because this is not a patient case from one single person. I see probably 3, 4, 5, 6 people a day with fatty liver disease. And I can just make up a case right now on the average patient that I see with fatty liver disease. So today we're going to talk about Jim. Jim is not a real person, but he could be. He's a conglomerate of thousands of people suffering from fatty liver disease. So Jim is a 48-year-old man. He has prediabetes, mild hypertension, so his blood pressure is a little bit high, and he was sent in by his primary care doctor because he had mildly elevated liver enzymes found on routine blood work. So Jim went in for an appointment for his yearly physical and whatnot. He had some blood work drawn. He was called a week later, and he was told that his liver function numbers were a little elevated. So his AST, which is one of your liver enzymes, was 48, and his ALT was 65. And everything else looked okay except for a slightly elevated cholesterol and a borderline elevated blood sugar. Jim works at a desk job. He drinks 1 or 2 drinks every few weeks, so not really a lot of alcohol. And Jim's about 5 foot 8 inches, and he weighs 225 pounds, and that gives him a body mass index of 34, which is considered obese. His physical exam is otherwise normal, and he basically lives a regular life and feels fine. So how do I approach a patient like this who comes in for elevated liver numbers? Well, you start with the basic stuff. So we don't quite know yet that Jim has fatty liver disease, even though he is the topic of today's talk, which is about fatty liver disease. Jim doesn't know it yet. So we start off with the regular serologic workup, meaning we do some more blood testing. Test for a bunch of different things that can cause elevated liver numbers, including hepatitis and some metabolic problems, autoimmune problems, iron overload storage problems, and all kinds of other things. So there's like a panel of blood work that I pretty much send off routinely if I see someone with elevated liver numbers, even if it's more likely that it's fatty liver disease, because you can have other stuff in addition to fatty liver disease. So you don't want to miss someone who has an iron overload condition or an autoimmune hepatitis or hepatitis B or C. If you're not looking for it, you'll miss it. So you have to check for all this stuff. And then you also do an ultrasound of the abdomen, just a basic ultrasound that you can do at any radiology place. And that will give you a picture of the liver to make sure that everything's good in the plumbing of the liver and make sure that everything looks good in terms of the liver cells. Are they fatty? Does the liver overall look inflamed? Is there a tumor or a mass or a cyst in the liver? Is there a biliary blockage? You know, all the gross stuff to look for that's obvious on ultrasound you should look for. And once that's done, we come back to the office and we go over Jim's blood work, and Jim has basically a negative serologic workup. Everything is fine. And the ultrasound just shows fatty liver. They call it in the report hepatic steatosis, which is the word for fat in the liver. So what do I do next? Well, I have the benefit of having a FibroScan machine here. So we do a FibroScan, which is a technique that is like an ultrasound, but it measures the amount of fat in the liver and also can tell if you have something called hepatic fibrosis, which is liver scarring, which is much more serious than just plain old fatty liver. So we do a FibroScan here in the office. It takes about 3 minutes, and the machine tells us that Jim has moderate fatty liver and no fibrosis. So his steatosis score is 2, and his fibrosis score is in the normal range. So that's good for Jim. He does not have any end stage or what should I say, complicated liver disease yet from this fatty liver, but he definitely has fatty liver and his liver enzymes are up. So let's talk a little bit about terminology. What does this even mean? There's a bunch of different terms that are thrown around, and then recently they changed all the terminology to confuse everybody. So I'll go into that for a minute, and then we'll talk a little more about what causes fatty liver disease before we get to the treatment. So the terminology, this fatty liver used to be called MASLD, or non-alcoholic fatty liver disease, to differentiate it from fatty liver that comes from drinking too much alcohol, which is called alcoholic liver disease. And there's also the term NASH. NASH is non-alcoholic steatohepatitis. People with NASH usually have more inflammation, and it's a more advanced form of the umbrella term of just fatty liver disease. And then there's also fibrosis and cirrhosis. So fibrosis is when you start to build up scar tissue in the liver, and cirrhosis is when there's end-stage liver damage from progressive scar tissue and other problems that I'll get into. And now, to confuse us more, just last year, or earlier this year, they released new terminology for fatty liver disease, and they changed some of the terms. And now, MASLD, which is non-alcoholic fatty liver disease, is now called MASLD, which is metabolic dysfunction associated steatotic liver disease. That's a mouthful, so we'll call it MASLD, MASLD. And NASH, instead of non-alcoholic steatohepatitis, now it's MASH, like mashed potatoes, MASH, metabolic dysfunction associated steatohepatitis. So if you notice, they got rid of the terms fatty and they got rid of the term alcoholic in both of these terms. And that was done based on a consensus from liver doctors around the world. So there was a global community consensus that they should change this. There were surveys, there was a whole panel, and they said that we need to have more affirmative, non-stigmatizing names for these diagnoses. And I agree with this in some respect, meaning that the term alcoholic is often confusing to patients. They think that we're calling them alcoholics when we're actually just talking about what they see on the biopsies. And also, the term fatty offends people just in general, which I understand. So I get it in terms of changing the terminology, although intrinsically I just don't like when they change terminology that's been used for so many years, because everybody knows what NAFLD and NASH means, and now people have to think about what MASLD and MASH means, and it's just like more complicated stuff to think about. I guess that's not a great argument against change, but maybe I just like the old way. Anyway, it is what it is, and this is the new abbreviation. So there's no more NAFLD and no more NASH, and it's all about the MASLD and the MASH. And they also coined a new term, which is actually pretty cool because there are a lot of patients that fall into this category, and we never really had a good name for them. They coined a new term called MET-ALD. So MET for metabolic, and then ALD for alcoholic liver disease. So that's like the combination of MASLD plus alcohol use. So if you drink more than 140 grams of alcohol per week as a female, which is like 10 drinks, or if you drink more than 210 grams per week for a male, which is like 15 standard drinks, that's per week, by the way. And you also have fatty liver changes based on having diabetes or obesity and whatnot. So it's the combination of these two things together. It's excess alcohol use plus fatty liver changes from metabolic syndrome. That's called MET-ALD. So that's a new one, but it's actually useful because we never had a term for that before. And I also like to make the distinction here between different people say these words differently. And it's a silly thing to say, but I have to say it because I like to stick with one way of saying things, and I'm not going to switch back and forth. So we will call this MASLD, not MASLD. Lots of people for some reason, call this problem MASLD, MASL-D. That's not the way it's in the literature. That's not how we talk about every other condition in the world. And an acronym, which is a bunch of letters that stands for a bigger phrase, like MASLD is an acronym. You say that all as one word. That's what an acronym is. So you don't say that someone who's having a major heart attack is having a STEMI. You say it as a STEMI. That's the standard way of saying an acronym. You pronounce it like a word. So you would say MASLD, not MASLD, like many people say. I don't know why they say that, but they do. The other way in medicine that we say abbreviations, it's called an initialism. So you use the initials and you say each letter. For example, DNA. You don't say DNA, you say DNA. There's lots of words in medicine that are pronounced as initialisms. I don't know who makes these rules. It's kind of like if it sounds like a cool word to say, you do it as an acronym. You pronounce it like a word. If it sounds like awkward, then you pronounce each letter. But that's just the way it is. So to have two different ways of saying something, an initialism and an acronym in the same word, that doesn't make sense to me. You wouldn't say MASLD unless there was a hyphen there. Then you would say MASL hyphen the letter D. Anyway, that's semantics, but I love it. So we're going to call it MASLD and MASH. And that's the way it is. And all the other gurus out there, they can say it how they want, but we're all secretly laughing at them. Anyway, what does MASLD mean? It means that more than 5% of the liver cells have fat in them. Basically, it's called macrovesicular steatosis. So if you look at a liver cell under the microscope, there's a glob of fat basically in the liver cell that you can see under the microscope if you look closely enough. And if there's more than 5% of the liver cells that have fat in them, that's considered MASLD. Now, not everybody gets a biopsy, but that's just the working diagnosis of what you would see on a biopsy if someone had this disease. Now, we pick it up on liver enzymes or ultrasounds and other tests like FibroScan, and we're probably underdiagnosing it because if we biopsied everybody, we'd probably find it much more commonly than it, because by the time it shows up on an ultrasound, it's already more than just 5% for most people. That being said, we're not going to run around biopsying everybody who has mildly elevated LFTs who probably has fatty liver, because that would be ridiculous and the risk would not be worth it. So just realize that when someone has fatty liver on an ultrasound or their enzymes are up, it's already definitely well there and not a subtle finding. And this also means that they're drinking little to no alcohol. So in women, that's like less than 20 grams per day, and in men, that's less than 30 grams per day. So a standard drink is about 14 grams of alcohol. So if you're drinking as a woman, less than about 1.5 drinks per day, and if you're drinking as a man, less than 2.5 drinks per day, that puts you into this MASLD category. Now, your liver numbers can be normal or just mildly elevated with fatty liver, with MASLD. But we use the term MASH, again, formerly NASH, so metabolic associated steatohepatitis. That's when you have MASLD plus more severe cellular inflammation and cellular injury on the biopsy. So you don't just have the fat globules in your liver cells, but the liver cells are angry, they are inflamed, and some of them are basically injured from the fatty inflammation due to the fat in the liver. Typically with MASH, the liver numbers rise even more, and you can also see people developing fibrosis, which is scarring in the liver associated with MASH. So MASH is the pathway to get fibrosis. It's fat in the liver plus inflammation, cell injury. The body tries to heal the cell injury. The liver lays down scar tissue in the form of collagen, like it does everywhere else, like your body does everywhere else, to help heal inflammation. However, the inflammation is ongoing. The collagen is being laid down to heal something that's still causing inflammation, and the cycle just continues, and you keep laying down more and more collagen in your liver, and the cells are more and more inflamed, and this is called fibrosis. And eventually, the liver gets stiff and dysfunctional, and if left unchecked, this ongoing fibrosis and inflammation pathway will lead to cirrhosis. Cirrhosis is when you have end-stage scarring in the liver, there's architectural distortion of the liver tissue, the liver becomes hard and nodular, and you have severe loss of liver function and multiple other complications that are the topic of another discussion. But cirrhosis is not a great condition. It means your liver is not functioning. So how much of the world's population has MASLD, fatty liver disease? It is more than 30% of the world, and the prevalence is rising. So it's a big problem, and by 2030, not that far in the future, people are saying there's going to be a 2 to 3-fold increase in the number of people who have metabolic associated steatohepatitis, as well as all the other problems that go along with it, like liver cancer and other related causes of death, like cirrhosis. So it's going to be a big upcoming problem in our world in the pretty immediate future. There will be a massive increase in the number of people who are being diagnosed with liver disease as well as dying from comorbidities that are associated with liver disease. So the time to do something about this is now. And what's the biggest risk of dying in people who have MASLD? Well, it depends on how advanced it is and if they have fibrosis or not. So fibrosis is the major problem that causes issues in people who have MASLD. So if you have MASLD without fibrosis, basically you're at risk of other metabolic associated conditions that are potentiated by the liver inflammation as well. And really it's cardiovascular diseases, so heart attacks, strokes, problems with blood pressure, etc. And it's cancer. So people without significant fibrosis who just have a fatty liver, they die from other stuff. They don't die from liver disease. These are often younger people. They die from the associated cardiovascular diseases, and they die from other cancers that are related more to the inflammation that goes along with all the risk factors for this metabolic associated liver disease. They're not dying of liver cancer. That happens later when you develop cirrhosis and fibrosis. They're dying from regular causes of cancer that everyone knows about. And those cancers are being driven by inflammation because MASLD is a total body inflammatory situation. And all the fat that is associated with having fatty liver is alive. It's an active, hormonally active and inflammatory active organ. And the fat cells are creating total body inflammation. And total body inflammation causes your risk of many different cancers to increase. So those are the two things, cardiovascular diseases and cancer. Now, when you develop liver disease on top of the inflammation, so when you have fibrosis or cirrhosis, the biggest risk of death at that point is really coming from the liver diseases themselves, dying from liver cancer and other associated problems that are related to cirrhosis, which we've covered in previous episodes pretty thoroughly. So if you have MASLD, it's also associated or potentially causing the following health conditions. And this is a list of very common health conditions, and I'm sure that we all have or know someone that has several of these. So obesity, diabetes type 2, high blood pressure, dyslipidemia, which means your cholesterol is elevated, the bad cholesterol is high, the good cholesterol is low, and you have high triglycerides, cardiovascular diseases, sleep apnea, and chronic kidney disease. So MASLD is associated with these things, but also potentially could cause some of these problems. And these are all great topics to explore in the future, but today we're talking about the basics. So we're going to leave it at that. But how does it happen? How do people get fatty liver disease? How do they get MASLD? How do they get MASH? What is the, do you just wake up and you have it? Is it genetically predisposed? Is it related to diet and lifestyle factors? Well, it's complicated. There are genetic conditions. There are other things that can kind of predispose a certain person to getting one of these conditions. But ultimately, the common pathway for most people has to do with energy balance in the body. And it has to do with metabolism. And I don't mean metabolism like, oh, I have a slow metabolism or whatnot, because that's often not the cause in most people. In most people, it's a metabolic problem in terms of too much energy intake and not enough energy expenditure. So if you want to put that in layman's terms, it's eating too much. That's what it is. So your body, when you take in extra energy in terms of calories, so whatever you're eating has calories in it. Whenever you consume excess calories in surplus of what your body is consuming, meaning your basic metabolic processes in your body, your basal metabolic rate, just existing, breathing, maintaining body temperature, plus any exercise expenditure, and plus all the other stuff that you do throughout the day, all that stuff adds up to be a number of calories that your body is burning off in a day, and that number changes day to day and what you do and whatnot. But if you're eating in excess to that, those extra calories have to go somewhere. You can't just get rid of them. They don't just evaporate, and they get stored somewhere. And the human body's really good at storing calories as fat. So we evolved to store fat. We never know where our next meal is going to come from. The body's really good at keeping these calories for later, because we're at risk of starvation, basically from human evolution. And if we can hold on to extra calories, that's going to allow us to survive hard winters or until the next meal or whatnot. Now, your body stores fat in really two major places. It stores it in the subcutaneous tissue, which is regular old fat when someone gains some weight. It's the kind of fat that you can physically hold on to with your hand. You can find it around the midsection, around the lower back, around the thighs or the hips. And typically it's the kind of fat that you store calories in first. But there is a predetermined limit as to how much fat someone will store in their subcutaneous storage before it kind of saturates that space and has to spill over into somewhere else. And that is determined by people's genetics and all kinds of other things that are maybe not fully understood. Why do some people gain fat in certain places, and some people gain it in their belly, and some people gain it in their hips, and some people gain it in their thighs or their buttocks? Nobody really knows, or maybe somebody knows, but I don't know. But it's definitely part genetic where you store your fat. But that being said, you're born with the genes you have, and you can't really change that. So some people will store a great degree of fat in the subcutaneous space, and they won't develop a lot of the other type of fat, which is called visceral fat. And some people will store a lot of their fat in the visceral compartment, which is much more dangerous. And you don't have much say as to where your fat goes. But when you take in too many calories, your body has to store them somewhere. It tries to store the calories as fat in the subcutaneous tissues until those are full. And then the next place that you store fat is in the visceral fat. The visceral fat is the kind of fat that builds up in the abdominal cavity. It surrounds your organs. It is the kind of tense fat that you see in people who have a protuberant abdomen that kind of looks out of proportion to the rest of their body. So you often see people with visceral fat issues who have skinny arms, skinny legs, a skinny butt, and a big protuberant belly. And that is by far the more dangerous type of fat storage because it increases the risk of all kinds of other diseases. And it is much more inflammatory for the body in general to have visceral fat as opposed to subcutaneous fat. Subcutaneous fat tends to be the more benign type of fatty storage, where visceral fat, which is the fat that surrounds your organs, your liver, your heart, your pancreas, your kidneys, the bowel, and inside the abdominal cavity, that is much more dangerous in terms of a metabolic standpoint. And it's not until you start to spill over extra calories into visceral fat that we have to talk about the concept of insulin resistance, which is the issue that kind of underlies fatty liver and metabolic syndrome. So what is insulin resistance? Well, first we have to look at what insulin does for the body. Everybody knows about insulin. It's a hormone that everybody knows the name of, I think. But why does it exist? Where is it made? It's made in the pancreas. And what happens is when you eat, insulin levels go up. And the purpose of the insulin is to help to push the blood sugar into cells. So insulin pushes the blood sugar into your liver cells, into your fat cells, into your muscle cells. Basically allows your body to use the glucose, which is the blood sugar, that's in your blood and get it into the cells where it belongs. And then it can go into the metabolic pathway and be used for energy, etc. So you need insulin to balance your blood sugar, and you need insulin to get your blood sugar into the cells where it belongs to engage in the metabolic pathway as energy. So when you eat lots of calories, more than you should, and you build up visceral fat, like we just talked about above, this visceral fat is inflammatory. It is not a benign tissue. It's not just cosmetic. It, for some reason, releases all kinds of inflammatory mediators and hormones that increase the risk of all kinds of other diseases, as well as cancer and heart disease and blood clots and inflammatory conditions, and you name it. But also it causes insulin resistance from this total body inflammation. The cells in your body start to respond less appropriately to insulin. So for the same amount of insulin in your bloodstream, the cells start to care less about it, and they start to allow less glucose in because they are becoming resistant to the insulin. So if your cells are sensitive to insulin, that's great. A little bit of insulin, your cells will open up, glucose will come flowing in, blood sugar will drop, and everyone's happy. Now, if your cells are resistant to insulin, the blood sugar rises after a meal, your pancreas releases insulin, it doesn't do as much in the tissues. The blood glucose can't get into the tissues as well because they're insulin resistant, and the doorway is closed because insulin kind of opens that door to get the glucose into the cells. And what happens is your blood sugar goes up. And now what happens to your pancreas? It says, whoa, why is the blood sugar high? Let's release more insulin. Clearly, we didn't release enough insulin. So the pancreas starts to release more and more insulin to keep the blood sugar numbers normal. And it does it for a while. So now your pancreas is releasing twice as much insulin just to keep your blood sugar normal. And your cells are getting the sugar they need, except it takes twice as much insulin to get them there. And as time goes on, more visceral fat builds up, more systemic inflammation, total body inflammation happens. You get more and more insulin resistance as a vicious cycle. Often people have decreased muscle mass. This happens with not exercising and other conditions, but if you're not taking in enough protein, not exercising, you also have decreased muscle mass, which contributes to more insulin resistance, since muscle is one of the great places that you can dispose of glucose, and your muscle cells are sensitive to insulin. So if you build up more muscle, that will allow you to become more insulin sensitive. Now, the opposite is when you lose your muscle and you build up all this visceral fat, that you are now becoming more and more insulin resistant. So the pancreas makes more and more insulin. This cycle goes on for years, and the pancreas is working at 110% capacity until, like every other organ that's pushed to its limit, it kind of fails. And now the pancreas cannot make enough insulin to satisfy the body's need for insulin because of this ongoing insulin resistance. And what happens is the cycle worsens and worsens until the pancreas just can't keep up. And now the blood sugar, no matter how much insulin the pancreas makes, it's not going to come down. So that's when you start to develop prediabetes and eventually diabetes. So by the time you notice that you're pre-diabetic or have diabetes, this problem with insulin resistance and an overworked pancreas and total body inflammation from visceral fat and other conditions, that's been going on for years already. By the time you see fatty liver, elevated liver numbers, and these other metabolic conditions happening, the horse has been out of the barn and it's gone. It's in another state. You're never going to go back to the way you were without some pretty significant lifestyle changes. At that point, it's not really a wake-up call anymore. It's that you have a full-blown disease, and now we have to do some damage control. So the liver is key in this whole insulin resistance pathway, and the liver, which I didn't mention, can also store excess calories as fat. So how does it do it? When blood sugar is high or there's excess fatty acids in the bloodstream from inflammation, the liver can produce fat. It's called de novo lipogenesis. So the liver can take sugar, and usually it stores sugar as glycogen, but the liver can also store sugar as fat, which it doesn't like to do and it's not supposed to do, but it can do it because the liver is pretty cool. So the liver will take one for the team. It will store extra calories, which is sugar and lipids in the blood, and it will store them as fat in the liver, which leads to fatty liver. So insulin resistance and fatty liver are closely related, and they are both parts of the same condition. Now, once you have insulin resistance and fatty liver, since the fat cells in the body are no longer sensitive to insulin, what happens there is that there is increased generation of free fatty acids in the blood from the fat cells in the periphery, and that also drives elevated blood sugar, and you get more lipogenesis in the liver and more storage of fat in the liver, and that leads to more insulin resistance, and you get more free fatty acids in the blood, and it just is a cycle that spins and spins and spins, and every time the cycle spins, you get more inflammation in your body because of all these conditions, including the visceral fat problem, and there you are. So when a patient's diagnosed with prediabetes or MASLD, this issue is going on for years, the pancreas is now screaming for help. The best time to make a change was 5 or 10 years ago, but the second best time is right now. So lots of patients take these diagnoses, prediabetes, fatty liver disease, they take them lightly and say, oh, it's prediabetes. It's not really diabetes. Or, oh, it's just a little fatty liver, right? But by the time you've got to this point, you've been in a metabolic crisis for years. The time to think about making changes was 5 or 10 years ago. The time to actually do something about it is now. This is a flaming emergency when it comes to metabolic health. So what can you do? What's the point of all this discussion if you can't do much about it, right? So what can a person do at home to start treating fatty liver right now? And by the way, I'm taking this from the MASLD practice guideline on fatty liver disease that was released last year. And I'll link that in the show notes below in case you want to take a deeper dive into the 30-so page article that encompasses these guidelines. But what can you do about fatty liver? Well, there's two things really that you can do at home for free right now today. And the first one is starting with weight loss, and the second one is starting with exercise. So weight loss is the main focus of treatment of fatty liver disease, And it only takes a 3 to 5% weight loss to improve hepatic steatosis on a biopsy. Now, it doesn't really fully improve it, but that's where the healing process starts. So only 3 to 5% of your body weight, to lose that, starts the process right away. So that's pretty cool. This process took many, many years to happen. So as soon as you can start to turn that switch off and allow the healing process to start, the better. Now, it takes much more of a weight loss to really improve MASH and to improve tissue fibrosis. It takes about 10% or more of body weight to be lost to really make a major improvement for MASH and fibrosis. But again, you start somewhere. You can't just lose 10% of your body weight tomorrow unless you go have something amputated. So you have to start somewhere. And for Jim, our 225-pound man, he's going to start seeing benefits in terms of his metabolic health with a weight loss of only about 7 to 11 pounds. So that's pretty amazing. I mean, most people can do that pretty quickly. Now, it's going to be much harder to keep that weight off, and it's going to be much harder to lose additional weight because he'll have to lose about 25 or more pounds to really change his future health outcomes. That's like more than 10% of his body weight. But that's doable in the future. It's just that you have to start somewhere. So the studies all kind of show what everybody knows, which is that weight loss is really challenging. Maintaining lost weight is even harder. The stats on weight loss are pretty grim, and it turns out that only about 10% or less of people can really lose weight with diet and lifestyle changes alone, and that 95% of those people who actually do lose some weight in the first year, if you follow them out to 5 years, most of them put the weight right back on. So telling people to lose weight is often just lip service that we give our patients because only a very small minority are able to do it, and even less than that can keep the weight off. So instead of just telling people to lose weight, some counseling is usually in order. And these guidelines also go into the fact that the physician can't really do it alone. There's just not enough time. Weight loss is such a huge topic. It takes into account so many different things in someone's life. It's an entire lifestyle change. I can't cover that in a 11-minute office visit. It's just not possible. And you need more routine follow-up than, hey, I'll see you in 3 months or 6 months or a year. You have to come in, and it's an ongoing lifestyle change. You can't just do it in a quick visit. So it is a multifaceted approach. You do really need physicians, you need dietitians, you need psychologists, personal trainers, and other associated professionals to really help someone lose weight and keep it off. But what can I tell someone in the office, or what do I often tell people in the office to get started with? Well, you have to find a diet that works for you. That's really the bottom line. And the term diet is always a misnomer because a diet is just a way of eating. I don't mean you have to go on a diet, because that often doesn't work either. Everybody goes on a crash diet, they lose the 10 pounds quickly and just comes right back on. And we know that's going to happen. The stats don't lie. Any diet that's not sustainable for the long term is a waste of time. So you need to take in less calories ultimately, but you need an eating plan that is sustainable and sensitive to your preferences, your culture, your family, your lifestyle. If I tell someone to go on a intermittent fasting diet where they only eat fruits and vegetables, blah, 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 it's just not going to work if you can't make that happen in your life. Or if you have a cultural situation where you're always out eating with your family on Sunday nights, it's just not going to happen. So you need to get this stuff covered when you talk about diet. How do you like to eat? What do you normally eat? What's your typical meal that you eat? What's your work schedule like? What's your home schedule like? All this stuff needs to be briefly discussed. And this is why it's great to see a dietitian, because they can have the time and the resources and the experience to do these things. But in the office, the biggest pushback I often get from patients about making a diet change is some type of cultural or preference-based argument. And the one I hear all the time, maybe because I practice here on Long Island or because I have Italian ancestry, is that, hey, I'm Italian, I have to eat my pasta. Or, hey, doc, I can't change my diet. I'm Italian. I love food. I love this and that. And you can make up an anecdote for like every other culture. But this is the one I hear all the time, and I have to laugh at it because I'm also Italian and I like eating pasta as well, just like most people who are non-Italian like eating pasta as well. It's a thing, pasta's delicious. And I get that a lot of families are celebrating things with food constantly and too much food, but there's ways to make changes that also still respect your food choices and your family and your culture and everything else, but can still cut back on calories. I mean, there's ways to do it a little smarter. You don't just have to see pasta and eat all of it. You can cut back on portions. You can eat vegetables and cut back on some of the carbs, when you travel and go to Italy, you realize that Italians actually eat vegetables too. It's not all pasta and pizza and lasagna and meat and cheese. Those things are pretty delicious. I forgot cannolis too. It's not all cannolis, man. But real Italians, they eat vegetables too. And then they go for a walk around the block. So there's a lot of things you can do and still be Italian that cut back on some of the calories and make some positive metabolic changes. Now, you also don't have to make a thing out of it. So you don't have to tell your family. When you go for Christmas dinner, you don't have to tell everyone and make an announcement that you're cutting back on this and that. Just do it. Because when you tell people about it, then you have to hear everyone's opinion on it. You have to hear 10 opinions that make no sense. It brings attention to the situation. Now everyone's watching how much you're eating. Now everyone has to make a comment on it. And everyone's going to tell you to eat more. You don't have to actually do that. Just don't make it a thing. Just do what you have to do. You can eat smaller portions. You can eat more veggies. No one's going to notice. You can cut out the liquid calories. That's easy to do. Don't drink soda. Don't drink alcohol. Don't drink fruit juices. Cut out all the liquid calories. The beverage choices should be water, diet soda, and coffee. And if you want to have a small taste of dessert and you're able to control yourself, then have a small taste. But you don't need to have 5 pieces of dessert. You don't have to have an entire plate of dessert. You can try a sliver of this, a sliver of that, and keep the overall calories much lower than if you had 3 different desserts. Now, some people can't do moderation. And if that's you, you have to understand your own psychology. And perhaps you do have to do a more restrictive diet. And perhaps you do have to cut out certain foods or certain situations where you're going to overeat because you know that certain parts of your brain cannot be trusted around certain foods. And that's good. You should know that about yourself. It's important to recognize these things about yourself so that you can change them. The more logical parts of your brain can step in before you're in that situation and change things. But if you know that every time you have one bite of something, you're going to eat a whole plate of it, and there's nothing you can really do to stop it once the cycle is started, then you have to remove that thing from your life. And that is getting into the more psychological aspects of changing things, which is a great thing that we're going to talk about in the next episode. Now, you can cut out the low-hanging fruit type items of food, no pun intended. You can cut out liquid calories, processed sugar, which is like added sugar, refined grains, and you can cut out excess saturated fat. So not too much butter, not too much animal fats, and that is all good stuff for your liver. So your liver is much happier without excess fat, including excess saturated animal fats, without excess processed sugar, which comes along with all kinds of extra calories and is easily converted into fat in the liver, and without the liquid calories, which are also just processed sugar calories. And I should also mention, alcohol really should not be a source of calories in your body if you have liver disease, and it's bad for you in general. So if you have liver disease, please cut out the alcohol as well. If you must indulge, it's 1 or 2 drinks a week maximum. People who have liver disease are much more sensitive to the effects of alcohol than the average person. So it may have taken you years to develop fatty liver and liver fibrosis, but once you have that problem, you are much more sensitive to the bad effects of alcohol, and you really should avoid it completely if possible. Now, when you're selecting a diet, you really have to take into account your preferences and realize that there's really not a big difference between different diet styles as long as you're taking in less calories. So if you like to eat low carb, that's great. If you like to eat low fat, that's great. If you like to do intermittent fasting because it helps to control your overall food intake for the day, that's also great. But there is really no magic between any of these methods, and there's 5 or 10 different diets out there that all will help you as long as they're sustainable. You are not going to keep doing something if you don't like to do it, and if you do it for a month or so and then fail and go back to the way you were, then why bother? It's a waste of time. So you should, and it's actually worse than a waste of time because it programs your mind to realize that every time I go on a diet, it's going to fail. So what's the point? I might as well do whatever I feel like. And that's actually fake. That's not really the way things work. If you can sustain a diet change forever, it will make a change. It's just getting to that point where you can do whatever you choose to do forever. Because once you change the way of eating and things improve, when you go back to the way you used to eat, it's just going to go back to the way it was. There is no going back if you want to stay improved. So that's a mental switch that you have to learn how to flip at some point, and it just takes time. Now, the Mediterranean diet seems to be the most beneficial for fatty liver and other inflammatory conditions. It's also good for cardiovascular diseases. And in terms of being sustainable, the Mediterranean diet is quite sustainable. You can eat all kinds of good stuff. You can have olive oil, you can have all kinds of fish, you can have lean meats, you can have lots of vegetables, you can have carbs as long as they're not processed carbs. There's a million places to go look online about the Mediterranean diet. And it's also a good thing to discuss with a dietitian because there are a million different ways to eat the Mediterranean diet. There are many cultures that are based around food that eat in that style and have delicious food. So if you want to adopt a diet plan, that's a great one to adopt because it can be a sustainable diet plan forever. The other thing about diet I should add is that coffee for liver disease is beneficial. So if you don't have any reason why you can't drink coffee, if coffee doesn't give you heartburn, or if you don't have a heart condition, or you don't have a really high blood pressure problem, or you're not suffering from irritable bowel syndrome with diarrhea and coffee makes you go to the bathroom, then drinking up to 3 cups, they say, of black coffee a day is beneficial in terms of reducing hepatic inflammation, liver inflammation, because coffee contains many antioxidants and other properties. It's also a good source of non-caloric pleasure. So caffeine in and of itself has both benefits to making you feel good and also making you perform well in life. And that's a topic for another discussion. But people who drink no caffeine versus people who drink too much caffeine, those are the two ends of the spectrum. If you don't drink any caffeine, you're missing out on how much fun it is. If you drink too much caffeine, it interferes with your life. But if there's a sweet spot right in the middle where it increases mood, increases performance on tests and things like that, and sometimes you just need it to stay awake, but it also reduces liver inflammation. So it's a pretty cool benefit of coffee. Now, you can tell I'm obviously a fan of coffee, but the other thing I should mention is that black coffee is the best because you're not adding all kinds of junk to it. If you need to add a little milk or creamer, I guess that's okay, but you don't want to add sugar to your coffee because that's defeating the purpose. And don't even get me started on these 500 calorie drinks that you get from Starbucks or Dunkin' Donuts, because although they contain coffee, that's great, they also contain a ridiculous amount of processed junk food, and it's more like drinking a milkshake than it is drinking coffee. So don't fool yourself and think that your triple latte, frappuccino, whatever is healthy for you, because it's really not. And that falls into that category of something, if you cut that out, if you're drinking something like that every day or a couple days a week and you cut that out, you're going to reduce that amount of calories from your life. That can add up to a few pounds of fat at the end of the month. It's pretty amazing. And all those processed calories, unfortunately, go right to your liver and they promote inflammation and fatty liver. So do yourself a favor and just drink straight up black coffee if you can tolerate it. Now, the next thing I should talk about that's also relatively free, unless you want to go all in on it, is exercise. So independent of weight loss, exercise helps with your cardiovascular health and it decreases your insulin resistance. So it improves your insulin sensitivity, which is just what you want. Muscle is the ultimate anti-insulin resistance organ. So if your muscle is healthy and if you have enough muscle, you can use that muscle to burn off glucose. And if that muscle is like another place that you can use glucose, you can store a little in terms of glycogen in your muscle, and store a little calories in terms of glycogen in your muscle, but also increase muscle mass, increases your insulin sensitivity overall, and it increases your baseline metabolic rate. It's also a buffer to excess calories. So if you exercise and you build up the muscle mass in your body by a few pounds or so, you can eat a little extra calories, and those calories will not go to your visceral fat or your liver. It also makes you feel better. It makes you function better as you get older. You don't want to grow up into a frail older person that's going to fall and break something, and muscle is protective against that. And there's also innumerable mental and other benefits to regular exercise. So it helps with anxiety and depression and just makes you feel good. So coffee and exercise. Those are my two prescriptions. But moderate exercise 5 times a week with sessions of 30 minutes each is kind of all you need to get started. And it sounds like a lot, so you could always start with less and work your way up to that. But if you don't exercise at all right now, it's good to get started with anything you can do. But the studies say that 5 sessions a week of about 30 minutes each, which adds up to about 150 minutes a week of exercise, of just moderate exercise. So going out for a nice walk and getting your heart rate up a little bit, that counts. Doing some weights, that counts. Going for a swim, that counts. Going on the bike, that's great too. If you already exercise and you want to improve your metabolic health even more, if you increase your exercise by about 1 hour a week, that also shows some benefits in terms of your liver health. So if you're already out walking 3 days a week, you just need to bump it up by a good hour or so per week, and you will have some additional benefits. And if you're already out walking 3 or 4 days a week and you're not seeing the benefits you need, then you need to start adding other things, especially strength training. Everyone thinks that strength training is for either young people or for bodybuilders or people who want to look muscular, but that could be nothing further from the truth. Strength training is really for everybody. We are all living in a body with muscles. That's how we move. And we need to take care of those muscles and allow our bodies to age in a way that does not promote frailty and all these metabolic diseases. And the way out of that trap is by lifting weights. You don't need to be Arnold and lift ridiculous amounts of weight, but moderate weightlifting, as well as these moderate cardio sessions, are the key. The key is mixing them up. And we'll go into details at some point about how much to do in terms of weights, but anything you're doing is good. So more is better. The effect is proportional, meaning the more you do, the better it gets for your liver. There is no real ceiling. I guess there is a ceiling in terms of time and how much can you really work out, but if you're working out for an hour a day and you work out for an extra half an hour, that's better. If you work out for 2 hours a day, that's even better. If you're working out 20 hours a day, that might be a little too much, but I doubt that's the case. Just like diet, exercise needs to be sustainable. You can't burn yourself out. You can't go all out, maximum effort, balls to the wall, crazy exercises for a month, and you lose 10 pounds and you feel amazing, and you bought all the CrossFit t-shirts, and then you totally burn out and you have no energy and you never want to work out again. Or you hurt yourself, even worse. You hurt your knee or something like that. So you want to do regular, strenuous exercise that you enjoy, but it needs to be sustainable. You can't let yourself burn out. If you feel like you're doing too much, too fast, you back off, because it's a lifelong change. It's not something that you're going to do for a month or 2 months or 6 months or a year. It is a lifelong thing that you have to do forever if you want to keep getting the benefits. And now the most important thing is you have to start today. Remember, tomorrow never happens because you're always living in today. You got to lace up the sneakers. You go out for a 15-minute walk today in your neighborhood, and you did your thing, and then tomorrow you do it again. And then you'll feel a little better. And one day you're going to want to go out for 20 minutes. Then you're going to want to go out for 30 minutes. If you don't want to go for a walk, go do some body weight squats if you're able to do those. Do you have dumbbells in your house somewhere? Go pick them up and dust them off and do some biceps curls or some shoulder presses or whatever move you feel comfortable with. Just do something now, right after you listen to this podcast, or tonight when you get home from work. If you're driving to work right now, just do anything. Go for a walk during your lunch break. If you're not doing that already, go do that. Just taking any action is better than thinking about it. You always have time to figure out the master plan as you go, but the most important thing you can do is just start today. Remember, tomorrow is not guaranteed. When you get to tomorrow, it's going to be today. It's always today. So start today. Well, there's a million other things to cover about fatty liver disease, diet, exercise, medications, and all kinds of other things. It's a huge topic to talk about, and I will definitely delve into this again in the near future. But next week, we're going to switch it up. We're going to talk about the psychology of change. I have a special guest coming on the show for the first time ever. Very excited about that. And I want to go into these questions. Why are some people ready to take action and some are not? And some will never be ready. So when you're diagnosed with something like fatty liver disease or prediabetes or some other problem, why do some people push themselves to take action and some people just think about it forever and let the disease take them? We're going to talk about the stages of change and what you can do and what your family can do or your loved ones can do to help facilitate positive actions. And that's the end of today's episode. I hope you enjoyed listening and you found this information informative. Please share it with a friend that has fatty liver disease or is looking to avoid getting fatty liver disease. I love questions and comments, so please leave me something on the social medias. You can find me under the username of RealGIDoc. You can also send me an audio message using the link below. I love audio messages, and I'll use them on the show to discuss your questions or your input. And if you really enjoyed this episode, make sure you're following on iTunes or Spotify or whatever your podcast player of choice is. Make sure to click that subscribe button so you won't miss our upcoming episodes. And if you are a super fan and you listened to every episode so far and you just cannot get enough of the Real GI Doc, please go leave me a rating on Apple or Spotify. Click to leave a review. write a little nice text thing in there, and that will help get the show out to other people who do not know about the Real GI Doc Show. All right, thanks again. See you next time.
That's it for this episode of The Real GI Doc Show. Make sure to join Dr. Gandolfo next time to explore another interesting topic in gastrointestinal health. And remember, the views and opinions presented in today's episode are for informational and entertainment purposes only. Nothing discussed in this episode should be considered or used as a substitute for medical advice, diagnosis, or treatment. If you're experiencing a health issue, please consult with a doctor or a medical provider in your area. Thanks again for listening to the show.